Hello and welcome. This is Professor Trudy Jordan. Today we're going to be discussing the concept of comfort, and with the exemplar being pain. So let us move forward and let's talk about it further. The objective of today's program is to discuss the physiology of pain, differentiate assessment variances over the lifespan of patients' lives, nursing process providing culturally competent interventions, and the management of comfort and the prevention of discomfort, which is not pleasant. The objective of today. In 2006, Kokaba came up with a comfort theory that basically talks about relief, ease, and transcendence in four contexts of the human experience: physical, psychospiritual, sociocultural, and environmental. Let's take a quick look at each of these. Physical comfort is our sensations, what we feel, what we taste, what we touch, and keeping our homeostasis in check. Psychospiritual is our awareness of ourself and our relationships to some other higher being, where sociocultural has to do with our societal and family relationships. Environment is totally our surroundings and what we are around. Are we around comfortable things or not? Physical. It is well documented that if we keep patients pain-free, with decreased stress and a very healing environment within the hospital setting, that our patient satisfactions go up, and it results in shorter hospital stays for the patients. It also provides for normal vital signs, giving them sleep and nutrition, and they finally feel like they have some form of sense of control. Now that we've discussed a little bit the idea and concept of comfort, let's talk about the exemplar, which is the opposite end of the spectrum. We're talking about pain. And mind you, it is very much a patient-centered experience, and we must, as practitioners, look at it as such. Pain is very much considered a sensory experience, and we see it and feel it through our sense organs. But to do this, we have to have an intact nervous system so that the stimuli that we're going to be talking about reaches the brain center so we can figure out what it is and how we're going to react to it. Pain is often called the fifth vital sign, and it requires assessment with each set of vitals and reassessment after being treated at all times, and must be documented by the practitioner. So where do we receive these stimuli from? First there's external and then there's internal stimuli. Visually, in the external world, we see whether it's painful or not. We can hear whether it's going to be painful or not. You can hear a bone crack. Olfactory, the sense of smell. Tactile, touching and feeling things. And gustatory, which is your stomach. Internally, gustatory is one of them, tells you whether we've had enough to eat for the day. Visceral, which actually is working with your internal organs, so that if you have pain in an internal organ, it is felt. And kinesthetic, perceiving direction and weight of movement. So all these areas can give you some form of stimuli for you to perceive pain. Now, the components of the pain experience consist of reception, where we actually receive a stimuli or some form of data. And then we have to go to perception, where we actually, in our brain, consciously organize it, translate it into something that we understand and we know what it is. And then finally, we have to react to it, which is the reaction, and we do whatever is appropriate based on what it is. Now, there's two major sensory alterations that can occur. First one is sensory deprivation. And this is where the person is not receiving any kind of meaningful stimuli. There's nothing coming in, so therefore they become more aware of what is around them. And it really alters perception, cognition, and emotion. When a person is sensory deprived, You're going to see things like yawning. They'll be drowsy and sleepy, a lot like some of you are in class in the afternoon. They're going to have a decreased attention span. They're going to be they can potentially become disoriented. They're not going to be able to concentrate. And then you're going to have a problem with nocturnal confusion, which is also known as sundowning. Sundowning. And sundowning can be very scary. I was once taking care of a little Italian lady. She must have stood 5'2". And I gave her her medications for the evening because she was going to have surgery the next day. And what she did is locked herself in the bathroom. Next thing I know is I'm getting a phone call on the floor from the police department saying there is a patient or a person calling them saying that we are keeping her at gunpoint and we are not letting her go anywhere. And when this poor little woman came out of the bathroom, finally when we broke into it, she was swinging the phone and she was biting and she was kicking, and it took like 8 of us to get her down. Sundowning is a true thing, and it can hurt somebody very bad. But also, we can also see with deprivation, apathy, hallucinations, and delusions. So we need to keep track of all these. On the other end of the spectrum, there's sensory overload. This is where we cannot process and manage intense, large amounts of information. There's increased quality and quantity of stimuli coming in. And it can be coming from all forces, internally, externally, and we just can't disregard what we need to get rid of. It's kind of sort of like learning how to do time management. Which one's a priority and which one is not? Now, when somebody is sensory overload, they're going to get irritable. They might have periodic or general disorientation. They're going to be tired all the time. They're not going to be able to solve problems very well, and task performance will go down drastically. They're going to have scattered attention, and the biggest thing is they're under stress. So they're going to have severe muscle tension, and they're going to possibly have cramping of muscles. So who are the patients that are going to be at risk for either or deprivation or overload? Well, deprivation, think about it. Confinement to non-stimulating environments. Think about the nursing home. Think about other homes, such as Takachali. Think about people with impaired vision and hearing. How about mobility restrictions, quadriplegics that are stuck in wheelchairs? People with communicable diseases, such as AIDS. In the ICU where I work, we turn on the TV and I put the speaker by their ear. We also bring increased family things that can surround them. We increase their activities as much as we can, and people contact. We also encourage family to call them frequently. Now, when it comes to overload, what's going to cause sensory overload? Anybody that's in pain. In the ICUs, think of an ICU environment. We've got IVs, we've got tubes, we've got machines, we've got beepers, we've got buzzers, we've got alarms. So in those areas, we want to try and create as much of a quiet environment as possible for overload, and subdued lighting has always worked well. And restrict their activity. And if they finally do go to sleep, we pretty much tell visitors that they're asleep and they really need their rest, and please, can they come back later? One of the gold standards in the healthcare profession was, for what the definition of pain was, came from McCaffrey in 1999. And he states that whatever the person experiencing the pain says it is, whenever the patient says it is, and as for long as the patient says it exists. This is pretty much where we all are, because the pain experience is about the patient. Other definitions: unpleasant sensations due to noxious stimulation of nerve endings, discomfort due to irritation of nerve endings, and your book defines this as an unpleasant sensory and emotional experience associated with actual or potential tissue damage. So therefore, care to patients must include both the physical pain, where we're going to be giving them their medications, and the emotional experience, where their mind is at and what their mental status is at that point. Now, mind you, the major reason people seek health care and healthcare professionals is because they're in pain. And you must understand that it is extremely very complex and it is very individualized. It can go from minor to severely debilitating that can put people down in their bed. And it will eventually affect somebody's quality of life and what their activities of daily living are involved in. So what really is the function of pain? Well, it's a warning system. It tells us that our body's about to experience some form of tissue damage, and it activates our protective reflexes by initiating our fight or flight mechanism. It also aids in helping us to locate and diagnose a problem, because lots of people, like with gallbladder inflammation going on, it actually radiates to the right shoulder, and that's where the location is, but yet the gallbladder's in the abdomen. But it also serves as a measure of effectiveness of our treatments. Did this pain medication that I gave this patient, did it take care of them? So what is our role as nurses? First of all, we must assess the pain. We use a pain scale. We want to know the site. We want to know the intensity of it. Then what we need to do is take those findings and communicate it to others who can order medications for us, such as the physician, an ARMP or a PA. And then assuring that we're giving the patient adequate relief. And then eventually, after we give the medication, we need to go back and re-intervene and see, did the medication help the patient? What was its effectiveness? And if it's not, if it's not doing what it's supposed to be doing, then we need to go back and re-communicate with the physician that we need something else, that this is not helping this patient. You must remember, we are the patient advocate. We are the go-between between physicians and patient. So what are the consequences of untreated pain? Number one, the poor patient suffers unnecessarily. They can go into physical and psychosocial dysfunction. When you're in pain, your body goes into what we call a hyperdynamic state. So you're going to have increased respirations and cardiac workload. They're going to have impaired recovery. It can cause immunosuppression, sleep disturbances when you can't get comfortable, GI motility, and then increased catabolism. Catabolism, remember, is the destructive phase of metabolism where we're releasing energy, and it's going to increase muscle spasms and or contractions. And then we're going to have increased morbidity, and that is usually secondary to respiratory dysfunction and respiratory failure. Now, the physiology of how we perceive pain is based on our nociceptors. These are our primary sensory neurons, and they're in all body tissues except our brain. They are what are going to detect tissue injury and damage, but they also evoke our sensations of touch, heat, cold, pain, and pressure. Now, there are 4 major steps in the process of nociception. The first step being transduction. This is where we take a stimulus and convert it into a neuron action potential. And this can become from something mechanical, thermal, or chemical. And what happens is the noxious stimuli causes tissue damage, and we release chemicals. These chemicals are going to activate our PAN, or our peripheral afferent nociceptors. And then they fire the action potential directly to the spinal column, where it is going to move up to the brain. The second step in this process is transmission. This is the movement of the stimuli, or action potential, directly up the spinal cord to the brain. And it is believed that possibly a neurotransmitter called substance P is responsible for this transmission up the cord. The third step of the process occurs actually in the brain, and this is the perception, where the pain and the stimuli is recognized, defined, and responded to appropriately. But it depends upon the pain and its site. And there's many, many brain structures that are used in this process to be able to accomplish this. And the last step is modulation, the descending system. This is where the neurons, after we have perceived the pain, decided what it is, and how we are going to respond to it, sends neuron signals back down for our response. And as neurons are coming back down, it stops the ascending impulses from going up to the brain. And it usually includes signals like various substances such as endogenous opioids, serotonin, norepinephrine, and prostaglandins. Now let's talk about the types of nerve fibers that are used to help with this neural transmission. First, there's type A fibers. They're myelinated and have a fatty covering on it. They're totally responsible for rapid transmission of impulses. So they elicit things like sharp pain, prickling pain, and localized pain. On the other hand, there are slow fibers, transmission fibers, which are your C fibers. They're unmyelinated, so they have no fatty sheath, and they're responsible for the transmission of dull pain, burning pain, diffuse pain, and aching. Now let's take a second to talk about the influences that are around us that change our sensory function. First, let's look at age. Developmentally, our hearing starts to change in our 30s. Visual changes start in our 40s. Changes of taste and smell occurs in our 50s. Proprioception changes in our 60s. And that's the awareness of posture and movement. So there's a change in our equilibrium. And thus, that's why older people have a tendency of falling, because their equilibrium is gone. Think of all the medications we give our patients. Narcotics, which can make them a little loopy. Blood pressure medications, which bring their pressure down and may cause them to fall. And sedation that we use. Cultural and religious factors include people like meditation and people who do yoga. Stress. When we're under stress, our body is in a hyperdynamic state, and it can really exaggerate the sensory functions. Then we have pre-existing illnesses. Think of the patient who is a diabetic and has neuropathy of their lower extremities. So they could be having pain in their lower extremities, but still have pain somewhere else. Personality and lifestyle, and smoking. So there's a lot of factors that can alter our sensory function. Now, what are the interactional responses? Well, first there's physiological. Remember, way in the beginning I said you have to have an intact nervous system for stimuli to get to the brain, be perceived, and come back down. So it's going to affect it if there is an alteration in our neurological status. Sensory-wise occurs in the cortex. This is where we actually recognize what the stimuli is. We decipher what the pattern is, where the area is, the intensity of it, and the nature of it is. And the sensation of perception occurs, and we feel the pain and interpret it. And then there's the affective, the emotional, the motivational, where they have fear, they might be angry, they might be depressed, and have increased anxiety, which also will increase the amount of suffering that the person is experiencing. Other interactional responses also include behavioral, the observable actions that express and or control the pain. But you have to not only look at the physiological, but the psychological and the nonverbal cues you're observing. What are you seeing? Facial expressions. Are they grimacing? Are they gritting their teeth? Are they guarding the area on which they had their surgery? Are they crying or moaning? So you have to look at nonverbal as well as physiological. And then you have the cognitive response. This is based off of our beliefs, our attitudes, our memories, and the meaning attributed to pain. You know, if all of a sudden a female comes down with breast cancer and their mother had had breast cancer, they might be more scared because of the experience that their mother went through. Thus, we have to take all this into play. Let's talk a little bit about the sources of physiological pain. First being mechanical. such as tearing. Passing a kidney stone is not a painful experience for anybody who's had it, because kidney stones are not nice, round, smooth stones. And as they're going down the ureter, they're actually tearing the internal part of the ureter itself, causing pain. Pressure, such as edema, cardiac patients that have severe peripheral edema, it's going to put pressure on neurons and on nerve endings, causing pain. Muscle spasms. Have you ever had a cramp in your leg where you're hopping up and down and bouncing around because it's so hurtful until you get it to break? And certain types of infections. When it comes to thermal, sunburn is the biggest. Yes, for you sun worshippers, yes, it can cause pain. There's days when you can't even put on a shirt. It hurts so bad. But then we're also talking electrical currents, whether it's AC, DC, lightning, and all those can cause pain. And then we've got chemical sources of pain, such as histamines, enzymes, prostaglandins, and caustic agents such as lye. Not that I really wanted to eat any soap when I was a kid, but I did have a patient once who was a little older gentleman who was admitted to the VA hospital. He had been at a family reunion, saw this wonderful blue liquid in a glass and thought it was blue Kool-Aid, so he drank it. Problem was it was antifreeze, and it burned all the way down and caused severe burns. Then we have biological, such as viruses and bacterial infections, and we have electrical burns, such as big burns from AC, DC, intake and output, which also goes with the lightning, but also shock states, all of which can cause sources of pain. So what's the physiological effect on the body with regards to pain? First, you're going to start seeing bronchodilation. And that's in the process of increasing your respiratory rate and heart rate. Like I said, you go into what we call hyperdynamic state, so everything kind of goes crazy. The sympathetic nervous system goes into complete function. We're going to have peripheral vasoconstriction, so they're going to be pale, and they're going to have their elevated blood pressure. They're going to have elevated glucose levels, and that's in the absence of diabetes. They're going to get diaphoretic, and they're going to have increased muscle tensions. Sometimes when you're studying and work in school and everything is getting to you, you start getting stressed, and the muscles start tightening. And then we're going to have GI mobility decreased, because the GI tract we're more busy worrying about the pain than digesting food. If it's left decompensated, now we're going to get physiologically sick. We're going to have nausea and vomiting. We're going to get weak. We start having irregular breathing patterns, and finally exhaustion. And most patients, if it's left untreated, will go into respiratory failure. Now, the psychological response to pain depends on a bunch of things. First being body image. That's going to affect your pain tolerance. Think about somebody who has had a severe burn to the side of their face. Not only is it going to be debilitating because their body image has changed, but it's going to make them concentrate more on the pain and make it worse. Personality plays a part based off of our coping mechanisms and patterns of our personality. Previous experiences are going to define coping strategies that we already have available from having pain previously. Pain trajectory is going to be the anticipated course of the pain experience. Is it a little cut that's going to get better in a couple of days? Or is it a big major surgery where we've had to break bone and put pins in and this and that? It's going to take much longer to heal. Okay? And this is going to precede the pain experience. Pain control, keeping the pain within our boundaries that we can cope with. And then anxiety, which is going to definitely decrease our pain tolerance and make it harder for us to control. Other psychological effects of pain are increased tolerance, where the patient is happy, content, and actively involved. And they experience very little discomfort from moderate pain. I've had patients where you go into the room and they're on the phone laughing and carrying on with your girlfriend, and they ask, well, what's your level of pain now on a scale of 0 to 10? And they'll say 10. but yet they seem perfectly fine. The other thing is increased perception of pain. And this is people that are depressed, lonely, angered, or bored. They're going to concentrate more on the pain. Thus, it's going to seem worse than it actually possibly is. Other sources of pain psychologically include interpersonal sources. Stress. How much stress you're under. How can you cope? What's your cultural aspects and ethnic access? I kind of think about, I remember watching a documentary, and it was on tribes that found tribes in the Amazon. And what they would do is, as for a boy to prove his manhood, they would literally pierce his chest with a stick. And he would have to climb up a large pole, and they would tie either ends of the stick to the pole, and they would have to swing coming down without saying a word. If they made it to the bottom without making a peep, they were considered a man. If they made noise, they were still a boy. And environmentally, we also have extra personal things, such as occupational noises. Like I said, think about the hospitals, especially the ICUs. Pumps, machines such as ventilators and monitors, overhead paging, visitors coming and going. We're bugging every 2 minutes. They're not getting any rest. So that has a lot to do with it also. Environmental variances that are going to alter how we perceive pain is nighttime. At nighttime, it's lots less activity or distraction. It's very quiet. It gets lonely, and if you're having insomnia, you're going to have an increased amount of pain because you're more involved with it because there's nothing to distract you. In daytime, it's going to decrease your pain perception because it's light, there's more activity, there's distractions. Now, you must understand, though, for people that work at night, this is going to reverse itself. So during the daytime when they're supposed to be sleeping, they're going to have increased pain. And at nighttime, when they would normally be active, it's going to be decreased. The other thing we have to look at is organizational features. People, it's going to influence the way people and the freedom that they have to openly. Environmental variances that are going to alter how we perceive pain is nighttime. At nighttime, it's lots less activity or distraction. It's very quiet. It gets lonely, and if you're having insomnia, you're going to have an increased amount of pain because you're more involved with it because there's nothing to distract you. In daytime, it's going to decrease your pain perception because it's light, there's more activity, there's distractions. Now, you must understand, though, for people that work at night, this is going to reverse itself. So during the daytime when they're supposed to be sleeping, they're going to have increased pain. And at nighttime, when they would normally be active, it's going to be decreased. The other thing we have to look at is organizational features. People, it's going to influence the way people and the freedom that they have to openly express their pain. Oncology units are very open about their pain because they're suffering from cancer, where on the med-surg floors it's going to be much more limited as to how they express their pain. So setting has a lot to do with it also. Sociocultural variances with regards to pain include demographics, your age, your gender, your education, and your economic status. Support systems. Who do you have around you to help support you through this painful experience? Social roles. Think about the head of the household who might then be diagnosed with cancer and be suffering from pain and various things. It's going to change the dynamics of the whole household. And culture. How you express pain in your culture. Drug use. Pain-related beliefs that patients have, and the way you're going to cope with them. Other things, your cognitive style. It is well known that higher achievers experience better pain tolerance than poorly educated individuals. So high intelligence and high achievers are going to be able to deal with it better. Cultural affects the attitudes and beliefs of a person. Attitudes and values give actual meaning to pain and what is it for. Sex. Females are much more expressive, you know that. My husband has always told me when I get into watching Titanic, and every time Leonardo DiCaprio goes down underwater, he says, "Oh, he drowned again," and I'm sitting there boo-hooing like unmercilessly. And then birth order. Firstborn usually has less tolerance of pain because they don't have anything to mimic it or to see from it. And like I said, it's well known culturally that Native Americans have increased levels of pain, and they're least likely to ask for pain medications. So it's kind of like all these things put together. Other things, your cognitive style. Other effects are going to totally depend on your past experiences. If you've never had an experience with pain, you're going to have an inability to cope because you have not built up any mechanisms to protect yourself. It's also going to depend on one's value systems and personal weakness. It is well known that older Americans take pride in not complaining in the hospital because they feel that it's a personal weakness and that it's just an inevitable part of getting old. Some others may just think it's deserved punishment for something they did. That's why they're in pain. So we need to look at all the fundamentals when we're looking at the person as a holistic person as to what their life is all about. Age developmentally plays a definite thing. Like I said, when you're younger, you're fearful. It's an unfamiliar experience. After the firstborn, they have a better tendency of dealing with it due to the fact that they have seen it out of their older adult sister or brother. So they can handle it. Older people are experienced. They know what to expect. Like I said, it's an inevitable part of growing old. Thus, we're not going to complain. We're just going to deal with it and hang in there. So we've got to look at it that way. Spiritually, persons with deep religious faith seem to have a higher pain tolerance. And like I said, it's again based on facts and attitudes. Because they have a better way of giving meaning to the pain. Because it's through their religion. It may be viewed as a punishment. It may be viewed as a test from God. Or it could be a gift from the higher power. So spiritual people seem to do better with pain tolerance than others. Now let's talk a little bit about endorphins. It's our natural body supply of opium-like substance. It's called endogenous morphine, or the morphine within. Endogenous morphine, matter of fact, if you think about it, people who are normal exercisers and exercise constantly, they say if they miss a day of exercise, they just have a crummy day because they don't feel it. Because when they're exercising, they get their endorphins moving, and the endorphins give them this morphine-type effect, and they feel good. And the endorphins are going to produce some form of analgesia, so it inhibits the pain perception. Now, it's activated by stress or pain, and they get it high court because they're located in our brain and our spinal cord and our GI tract, and they start being released. So I think every one of you, if you really want to start feeling this natural morphine from within, you might want to take 3 laps around the track during a break, and then you will feel the true effects of endorphins. Now, there are many pain transmission theories out there. The one that's most respected is the gate control theory. And this is where our peripheral nerve fibers are being altered at the spinal cord level. and it occurs in the dorsal horn of the spinal column and acts as the gates. So they're saying that as you perceive pain and the transmission goes to your spinal cord, if we put something in front of it and block the transmission going up to the ascending effects to the brain, we can stop the pain from being there. So like back rubs, giving a person a back rub, warm compresses if they have like an infiltrated IV, TENS units, which we will talk about in class, because they're stimulating the sensory nerves and preventing the ascending route of the nerve impulses. So what they do is cause a distraction, and they actually close the gate so it never makes it to the brain, and thus pain is not felt. So think of this. Which statement is really true? Psychogenic pain is not real. Regular administration of analgesics will not cause dependency. Tolerance to analgesics means a person will become addicted, or the amount of tissue damage, which will describe how much pain is associated with it. Ponder these. So this completes your 1-hour online module as it relates to pain. Ponder the previous questions posed, and then we will pick up a discussion on these questions when we get to the classroom, and we will finish 2 hours on pain. Thank you, and have a super day.